bit of a mix. If you're reading the conference program, you might be thinking, oh, this doesn't quite look like a very uniform mixture, but actually it is, because this is going to be focusing on the absolute bare essentials that you deal with in your daily practice. It doesn't matter if you're a postgraduate trainee, it doesn't matter if you've done your fellowship and you're practicing as a junior or a senior consultant. Remaining up to date and having a solid core base of knowledge on which to base very critical decisions is essential. And the fact that a gastroenterologist can never work alone, it is always a team effort. You need a good radiologist, you need a good surgeon, and you need to be able to follow good guidelines in order to make things work. So it is essential that we have a multidisciplinary approach to managing our patients. And such is the reality of the next session. It is titled Essentials of Hepatology from Guidelines to Practice. And I would like to request Professor Arif Amir Nawaz to kindly chairs. Okay, we do. Okay, so we'll be starting with the talks. I think our honorable chairs will be joining us momentarily. So first in line is Professor Dr. Najmuddin, and he will be presenting his talk on radiological evaluation of a liver mass. Now, liver masses are something that are the bread and butter of all our scans and radiological imagery that we see in our clinics, that we see in the wards. Professor Najam is one of Pakistan's most senior and most experienced interventional radiologists, and he has decades of experience in both adult and pediatric radiology. He's the founder and one of the main pillars behind the establishment of the Department of Radiology at Shaukat Khanam Hospital. And currently, he's also an honorary professor of pediatric radiology at the Children's Institute in Lahore. I would like to welcome Professor Najmuddin to our current session for his talk on radiological evaluation of a liver mass. Sir, you may take the stage.
Lesions and way forward as of today in handling these lesions. We'll start off. I do not have any disclosures except that these people who sell Promavest in Pakistan are chasing after and stepping on my tail all the time. Anyways, liver lesions. Initial characterization is mostly for the incidentally picked up liver masses, which we commonly encounter during our imaging, probably for something else. So if we are doing a renal scan, we'll probably pick up a liver lesion, and we end up sorting it out for most of the time. So prevalence of the benign focal lesions in adults is very high. That's very important to understand. And one lesion seen in up to 15 of the patients which we pick up incidentally would be benign. So accurate characterization of incidentally detected lesions is an important objective of diagnostic imaging, obviously in a clinical setting. So what has happened? The armament we have, which is obviously the cross-sectional imaging, we are using it more frequently. We are using for very soft indications as well. So we have an increased detection for most of these lesions. The quality of imaging has also improved. We have new imaging techniques. So, you know, we started off with ultrasound. Now we have PET CTs to help us in characterization. Characterization has become much more demanding. And the first step is basically knowing whether this is a lesion which is worth chasing after or not, if it's benign or malignant. So then once you're ending up with a benign lesion, even then it becomes a problem, because certain benign lesions will have different management pathways. And that's important to define which type of benign lesion we are dealing with. So obviously the objective of imaging is basically to help characterize the lesion as much as possible in order to avoid biopsy if we can, and the obvious morbidity related to the biopsy itself. So these benign lesions are very common, and even in the primary, in patients with known primary malignancy, you would expect to pick up these benign lesions, and completely unrelated to the pathologies, up to 30% of these patients. So this is a list of benign and malignant lesions. I won't go into the details, but The most important of these are the cysts which we come across in age-based patients. So if anybody is 60 and I see a cyst, I would be more confident in calling a cyst. Mangiomas, FNHEs, and metastases towards the malignant list, followed by hepatocellular carcinoma. So let's move on. Assume that I'm going to go through a number of clinical scenarios because this was a case-based session. So I assume when a lesion is picked up incidentally, has been identified on something which cannot further characterize this lesion. Say if this was picked up on ultrasound taken forward with Doppler and the basic assessments would not be in a position to characterize this lesion. So prior imaging does help. But if we are stuck up, then we move forward. And this could include even the baseline MR examinations, even with contrast. And then obviously it depends where the patient is coming from, what's the clinical background. So, we risk stratify these patients between low, average, or high risk patients. So let's take this example. So this was an ultrasound done for renal calculi, pelvic ultrasound for kidneys, with no known liver history, no oral contraceptives, and we end up picking up a lesion which is a targetoid kind of a lesion in segment 5 or 6 of the liver. So what do we do with it? The actual requirement is to basically, if we can possibly use contrast ultrasound, do an ultrasound and try to resolve and characterize this lesion. As you can see on this side, that this has actually kind of vanished, and this gives me the confidence that what I'm dealing with is a benign lesion with persistent flow obscuring the outlines. So I've kept these in order to safeguard, because if this movie didn't work, I would have had to show you these images. But I know from the dynamics of the lesion with sonoview or ultrasound contrast medium, that's a hemangioma, and that's the end of the story. We would not move forward from that point onwards. So what are the special imaging considerations? For definitive diagnosis, we require a dynamic scan. So this is irrespective of whether we are using CT, MRI, or ultrasound. All can give us the dynamic assessments. At least 2 dynamic imaging phases are required, which we all know about, arterial and venous. And the later they are, that is delayed arterial or delayed portal venous phase, the better it is to assess them. These phases are required for assessment of liver lesions, even in CLD, as stated by LIRADS. And I'm sure you're all aware of LIRADS. So now the focus has shifted in principle when you are stuck up with a lesion on basic imaging to move towards something which is much more robust at the moment. So, and that is basically the MR which we rely on. So anywhere, even in US or transatlantic practice or on the eastern side, if you end up having a lesion which you can't characterize essentially on the basic image, MR is the way forward. It's got superior tissue contrast resolution, but mind you, it does not have that spatial resolution which CT has. So there's a difference between the two. People who are happy using CT will continue to use and rely on CT because of the spatial resolution. It's got a safer contrast profile, whichever contrast medium you're using, and obviously it's radiation free. So I'll come to these later on as to what contrast mediums we have. So in contrast medium for MRI, so I'm moving towards the higher end of imaging. In contrast, which are available for MRI, you need to know which compartment do they opacify. So majority of the contrast mediums which we are using in our daily clinical practice are basically extracellular contrast mediums. There are only 2 of them available, which are hepatobiliary contrast mediums, and that's the benefit or drawback of one or the other. I'll come to it as we go and see the cases. And it's been proven that Primavist has made a huge difference in the overall characterization of the disease, and it's got an overall impact on the recurrence-free survival of the patient and initially assessed by the CT scan. So it is now become part and parcel of practice. So nodules which we pick up are up to 16%. These are in addition to what we've been picking up with the standard extracellular contrast medium in MRI or even on CT. So it will give us that arterial phase, the portal venous phase, and on top of that, after the delayed phase, it will give us a hepatobiliary phase as well, because it's excreted through the hepatocytes into the biliary tract. So the system for, or the algorithm for assessment of characterization of liver masses remains the same. We see whether it's enhancing or not. If it's not enhancing, we assume that it's most of these things, above all cis. And if it's enhancing, we move on to see which pattern of enhancement it has. The arterial enhancement has this kind of pattern in which it's hypervascular, has a REM type of a pattern, or even if it has diffuse pattern of arterialization, then you would think of malignancies. If it's the pattern is like this with diffuse hypovascular or peripheral type, it comes out to be this. But most important of all is the washout phase in it. Majority of the tumors would tend to wash out after the arterial phase, and that's what we aim to pick up with most of our imaging. The benign, relatively benign abnormalities would not wash out as well as the tumors. And this is how the next algorithm, which I'm sharing with you, will rely in principle on the washout phase in deciding between malignant and benign, and then further characterization. EASL 2018 has already taken up the contrast mediums, all kinds of contrast mediums in MR, and they are supporter of use of Ghetto acid enhanced MRI in most of these patients. So let's come to what I can comprehend better from ACR appropriateness guidelines, is that if you have an indeterminate more than a centimeter lesion on initial imaging with ultrasound, no suspicion of evidence of extrahepatic malignancy or underlying liver setting, if this is the clinic setting which you are looking at, what would you do? So we picked it up on ultrasound. Ultrasound is pretty good. As you can see, the figures in specific diagnosis up to 93%, and benign versus malignant distinction is up to 97%. And the values are pretty good. The accuracy is up to 88% for establishing a definitive diagnosis. MRI with and without contrast takes it up further to 95%. And if we use CT, the definitive diagnosis can only be achieved in up to 71% of the patients. So obviously these figures are in support of MR in contrast to other modalities. And in certain cases, like if you have a cyst and you're struggling to decide, you can use a unenhanced MRI as well. But look at the list of other things which are put up there. None of them are indicated or justified. Let's go through this one case. 53-year-old female, renal failure, transplanted, autoimmune hepatitis in childhood, an abdomen episode of pancreatitis, identified portal vein thrombosis, subsequently unenhanced because renal function is bad. A study was done which picked up a segment 5 lesion. So what do we end up due to renal failure showing? And we are now stuck with an indeterminate lesion. So this was done with the Premavist. And as you can see, this lesion on in phase and out phase, that's the basic thing. I won't go into the details, but the out phase shows the drop in signal within the texture of this tumor, which signifies that there's fat in it, which has moved out. T2 sequence shows increased hyperintensity, but the enhancement pattern is very confusing. So there is heterogeneous early and very early and late arterial phase, but it homogenizes on the actual portal venous phase, but it increases. And on the later phase, we are stuck with a situation where we have something which we favor for hepatocellular carcinoma. So, these patients will get some support from diffusion weighted images if we go from 400 to 800, but we do not have that confidence to call it a tumor. So this was biopsied, and it turned out to be a focal nodular hyperplasia. So the portal venous phase does help us in these situations where we are stuck up. Another situation where we have a patient with no suspicion or evidence of extrahepatic disease, but initial basic imaging has been done. Again, MRI does take us up to 91% as far as negative predictive value is concerned. We're stuck with the CT as well. It takes up us on certain studies up to 95%, but then again, eventually, if you look at the figures from ultrasound and enhanced dynamics, they are also ranging around the early 90s. Let's go through a case. So we have a 55-year-old female underwent CT, identified multiple liver lesions, and these were all hemangiomas, except for these two lesions, which were not typical, and we had to characterize them. So on angio, you can see they have a ring type of a pattern, and this outflow, or the venous outflow, is much better appreciated on the hepatobiliary phase. Again, hemangiomas very nicely visible up here, but we can't really tell on T2 what exactly we are dealing with. Diffusion weighted did not help us much. And then on ADC, we can see that they are concerning because of the restricted diffusion, they are concerning for tumors. We went back, looked at the CT, reviewed for something else which could tell us that whether it's a primary or a secondary lesion. And behold, on daughter gallium-68, we picked up a lesion which supported the presence of a neuroendocrine tumor. And it goes on. So I'll just jump the queue here, because majority of the situations when you have an extrahepatic lesion, you still rely on MR. This is a case in which, again, 71-year-old with ascending colon tumor, a liver lesion was picked up, colonoscopy confirmed adenocarcinoma ascending colon, and we ended up with this lesion. So you can see that on out of phase, we dropped most of the fat except for this portion of the fat, which did not drop out. T2 did not help much, but when we did contrast examination, it was not much of an help, except that on the delayed phase with the Primavest, we picked up this heterogeneous kind of enhancement. And we also noted that there was a lymph node. So, in a patient with colonic carcinoma, we diffusion weighted also showed us this image, lymph node to be strikingly close to the gastroesophageal junction. Endoscopy was done. The patient also had a squamous cell carcinoma. So now we are stuck with two primaries and a lesion which we don't think favors a metastatic deposit, at least on this hepatobiliary phase. What do? We biopsy it, and we eventually ended up calling it a hepatocellular carcinoma. So three malignancies at the same time. And the bottom line was that we went on to continue this characterization process. So one more thing was that ultrasound has a pretty high accuracy when used with IV contrast. I'll jump the cases because that will slow me down. So there are 8 scenarios which are being discussed with the radiologist as far as appropriateness guidelines are concerned, and most of them MR is right at the top with or without use of Primavest. Another case, a classical case, basically in this patient of prostate cancer, we're looking for metastases, and we ended up having hepatocellular carcinoma. This is how exactly we precisely can tell carcinoma from metastasis. Look at the arterialization of the liver lesion and the emptiness on the post-hepatobiliary phase imaging. PET-CT confirmed metastases in the superior mediastinum as well. Similarly, cholangiocarcinomas can be quite nicely characterized, and more importantly, what we can pick up is the sinister satellite nodules which these lesions have. These are much more easily and clearly picked up on the hepatobiliary phase in contrast to the basic diffusion-weighted imaging or early arterioportal phases. Simple things like lipomas, angiolipomas, they can also be very nicely characterized, and these patients can be saved from either doing surgery or even biopsy, given the basis that they saturate very well on MR and do not pick up anything on the hepatobiliary phase either. So you can also subcategorize them. We all know what LIRADS is doing. I think I would stress on the use of LIRAD more than anything else, because that's the brunt or the practice which we have right now. Everybody is looking for hepatocellular carcinoma, so at least we should have a standardized terminology and we should know how to classify these. This is a chart which I will not go into details. You obviously have been practicing, most of you have been practicing this flow charts for the LIRADS, but the basic concept is that we need to know benign, 100% benign lesions from 100% definitive, ACCs, and that's how we characterize them based on the images. And obviously, the treatment and prognosis relies on it, and it's a difference between continued surveillance and or definitive treatment for a lesion. But if you notice, the LIRAD-3 is the thing which becomes much more controversial. And I notice in our practice that we end up treating most of the patients which actually are in LIRAD-3 in our clinical practice because of the arterialization taking the fall for most of these lesions. So hemangiomas, you know that they are typical hemangiomas. They fill up, and you call them and categorize them as LIRAD-1. Fatty infiltration can be very funny at times, but still, if you know what you're looking at, you can still categorize them as LIRAD-2. And this is the one which worries us most. So if this is a lesion, arterial enhancement, equivocal portal venous phase, not venous emptying, a bit of venous emptying, this is category LIRAD-3. We should wait on it and follow it up with 3 to 6 minutes. Again, lesions which are smaller, LIRAD-4, lesions which are typical like this and larger than 2 centimeters and have all the other parameters, LIRAD-5. And on top of that, what we foresee in the future, just to end my talk, is that this is where we're ending up. Artificial intelligence, the neural network is being developed in which genetics are being encoded, and eventually we hope that effective classification of ACC tissue, the surrounding non-cancerous tissue, will be identified, and we can classify these lesions quite well. So be familiar with the typical images in a known clinical setting. The uncommons and overlapping imaging features are worrisome. Try to use hepatobiliary contrast medium in these cases. The challenging ones will require histologic analysis, and we do end up biopsying them majority of the times. LIRAD is a language, as I said. Let's stick to it so we understand each other, and do not short us to lateral thinking when you're looking at images which are funny and do not fall typically into the categories. Anyway, I'll end that because I don't think we're doing the quiz already.
Thank you. Thank you. Thank you, Professor Najam. And I'd like to take the time out to speak about our honorable chairs. I think the best 3 words to describe them would be a mentor, a comrade in arms, and a bright apprentice. Professor Anwar Ahmed Khan, arguably the founder of GI and hepatology in the country, and many present here are either his students or students of his students, and has exhibited a remarkable trait of always be ready to learn new skills at any stage of his career, and he's still teaching, still mentoring. Professor Altaf Alam, who headed the GI unit after Professor Anwar Ahmed Khan at Sheikh Zayed Hospital, again basically a continuation of the same wonderful trend of teaching and training. And Professor Shahid Sarwar, again a student of both of these wonderful senior consultants. He's heading the unit of medicine at Jinnah Hospital, Lahore. This, just to spice things up, this is the time, everybody's very hysterical before lunch. And, you crack the lightest joke, everybody starts laughing. But right now, at this point in time, everybody's eaten, so everybody's lazy. And you have a lot of substrates in your tummy, which I believe are the forte of our sister society, the PSG. So a running joke in our unit was always that when we say AASLD, it's not American Association for the Study of Liver. We always used to say AASLD means what do Anwar and Altaf say about liver disease? Because their words and their experience have always been such a wonderful inspiration for all of us. So thank goodness you've laughed. So, everybody wanted to have a siesta after lunch. So, it's always tough to, keep people on their toes after this. So